Thanks for joining us for this symposium. I'm BAppSc, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium.
A very warm welcome and a big hello to all of us who are joining today for this latest edition of LE&RN Symposium series. I'm your host, Dr. Ajit Mulay. It is my honor and privilege to introduce you all to today's guest speaker, Dr. Louise Koelmeyer. Dr. Koelmeyer is Head of Department of Health Sciences and Director of Australian Lymphoedema Education, Research and Treatment Centre, LE&RN, within the Faculty of Medicine, Health and Human Sciences at Macquarie University in Australia. She is the leading lymphedema therapist and educator and a renowned researcher with more than 35 years of clinical experience. She specializes in breast cancer rehabilitation and lymphedema management. Today, she will be speaking about a topic that is of significant relevance to both clinicians as well as patients. The topic of today's discussion is implementing a prospective surveillance and early intervention model of care in cancer rehabilitation. So without further ado, it is my pleasure to invite Dr. Koelmeyer. The floor is all yours, ma'am.
Thank you very much, Ajit. And hello, everybody watching this webinar, either live today or at a future time from the library. I am delighted to be here to give this LE&RN Symposium, and I'm really grateful for the opportunity. I'd like to thank LE&RN for the opportunity of doing this. We are very privileged here at the Alert Centre in Australia to be a LE&RN Centre of Excellence, and I'm really excited to be here at 7 a.m. in the morning in Sydney, Australia. And I'm really happy to share my experience. Ajit did say that I've been doing this for 35 years. I started when I was 5, just so you know. So this is where I'm from. So good day, everybody, and welcome. I'm from Sydney, Australia. If you haven't been across the ocean to visit us, please come down to our beautiful country. We're coming into the summer season and summer holidays and Christmas period. And very excited to welcome you both to my city and country, but also to my university and our Alert Centre. I have no personal financial declarations to disclose at this time. Our Alert Centre does engage in some research collaborations with some industry partners, which we are very grateful for. So the Australian Lymphoedema Education, Research and Treatment Centre, it's a very long name, so we're known as the Alert Centre. So we need you to stay alert for the next short period while I share my experience on this really important topic, which I hope is really relevant to both health professionals and individuals at risk of or living with lymphedema. To give you a bit of background about my centre and our program here in Sydney, our centre is a multidisciplinary, nationally and internationally recognised program based within the Faculty of Medicine, Health and Human Sciences at Macquarie University in Sydney. The 3 names in our program are the 3 arms of what we do. So education, we deliver education to health professionals who wish to become accredited or qualified specialist lymphedema practitioners and go off and work in the country and elsewhere. We train about 150 health professionals a year, and we're really excited to be able to offer our translational best practice evidence to the future workers in this area. We also are involved in translational clinical research that really integrates our clinical arm and our educational arm so that both our patients, those coming in for treatment in our clinic, and also our health professionals can have access to the latest evidence that we're involved in. And within our treatment arm, we have a multidisciplinary diagnostic, conservative and surgical clinics where again, we have patients coming into our clinic from all over the country for our specialist multidisciplinary assessment and management. We're about empowering individuals at risk of or living with lymphedema, and also health professionals to be the future leaders in this area of managing lymphedema, lipedema, and other chronic conditions. I have to acknowledge that much of the work that I share through this presentation and through our publications has to give acknowledgement to my team. I have the privilege of being the director of this Alert Centre team. We are a multidisciplinary team. We've been at Macquarie University since 2012, and we are really, truly multidisciplinary. We're made up of medical practitioners, both surgeons and rehabilitation specialists. We have imaging specialists and lymphatic anatomy specialists. We have plastic surgeons. We have lymphedema therapists, both occupational therapists and physiotherapists who are specialised and trained in lymphedema management. We have a research team and a support team that looks after all of the arms of our program. And we're delighted to be able to have some honorary professors who help to guide, give feedback to us to ensure that we're delivering the right messages to both consumers and to health professionals, and that we're staying true to being evidence-based. So what I'm going to cover in this presentation is something very dear to me and my research and clinical interests, and this is a model of care called prospective surveillance and early intervention in cancer rehabilitation. I'm going to talk about what the model is, going to share my reflections and observations of where this model stands internationally, and why we should potentially adopt this model, what is the scientific evidence behind it, and what do we consider important for being able to adopt this model of care, and where the opportunities are moving forward. And as Ajit said, I would be very happy to answer questions at the end of the presentation. So this is the condition that we're all here about, and that LE&RN is really driving and leading globally, this condition of lymphedema. Lymphedema is a significant issue for individuals going through cancer treatment. Individuals can be at risk of lymphedema by having surgery, radiotherapy, or trauma to the lymphatic system as part of their intensive cancer treatment, so a necessary part of their cancer treatment. But unfortunately, weeks, months after the cancer treatment, or even longer periods into years, individuals may develop lymphedema. And these pictures show what lymphedema can look like if it's been poorly managed or left to develop after, for example, breast cancer, gynecological cancers, prostate cancers, melanoma cancers, head and neck cancers. There's a lot we can do to try to prevent this condition developing, and that's what I'm passionate about and want to share about today. We know that once lymphedema develops, it's not only a physical condition, it impacts lives. It impacts people's lives emotionally, psychologically. It impacts people functionally and also financially, because there are lots of inequities across the globe in the assessment and management and the ongoing management of this chronic condition. So what is this model of care that I call the prospective surveillance and early intervention model of care? So what this model of care is about, and my vision is that all individuals at risk of lymphedema should have access to a prospective surveillance and early intervention model of care. This model of care can only work if it's embedded within a multidisciplinary cancer team. It can't be just led by the medicos, it can't be led by just allied health or nursing. It needs to be embedded and supported by the whole multidisciplinary team. And we need to have a screening or monitoring protocol in place and a clinical pathway in place for what happens when someone triggers early intervention in order to be effective. And I'm going to share what I mean by these things as we move forward. So the aim of this model of care is to detect subclinical lymphedema, or stage 0 or early stage 1 lymphedema, where we really believe that we can try to prevent progression to chronic lymphedema. And as a clinician, as an occupational therapist myself and lymphedema therapist, early intervention in cancer care is much more easy to manage than someone requiring extensive, intensive CDT treatment for a later stage lymphedema. So the key points of this model of care, so I would emphasize it's like a screening program to try to screen to detect lymphedema or subclinical lymphedema and intervene early. So ideally, all individuals who are at risk of developing lymphedema after cancer treatment ideally should have a pre-cancer treatment assessment. Now, it should ideally be a comprehensive assessment, and I'm going to talk about methods of how we assess for subclinical lymphedema, but ideally at time of baseline. We screen and we provide education so people are aware of what lymphedema is and that it may develop in the future. Obviously, our education is organised in a way that we don't alarm people at the time of their cancer diagnosis, because obviously they're going through a lot of stress and a lot of understanding of what's happening. So we need to give the education in a really slow drip filtering way so that they understand and can have that information retold to them later on. So a screening program means there's regular periods of monitoring with a comprehensive assessment. Then when someone triggers early intervention or the need for early intervention needs to be given in a timely way. I'm going to share what early intervention means, including compression therapy, skin care, exercise, and education, and that ongoing education throughout the cycle. And when someone receives early intervention, ideally, their measurements, their objective measurements come back to their baseline or close to their baseline, and then that individual moves back into the normal screening again. So my observations and reflections over my career of working in this area. In Australia, we can be in quite a unique position that we're a big island surrounded by water, and we can observe what's happening internationally in the field of cancer care, cancer rehabilitation, and lymphedema management. And in my career, cancer treatment has certainly changed significantly from, for example, every woman diagnosed with breast cancer previously had a complete axillary dissection as part of their standard of care treatment. Now that no longer happens. So we've had significant changes in our treatment. So when I'm observing what's happening internationally, I think we're doing really well in the breast cancer treatment world. There's some centres internationally who have got this model of care and are running it as standard of care. And there's other parts of the world that there's challenges in being able to implement it. And so I guess the promotion of this talk today is about how we can make this standard of care so that it doesn't matter where you live or whether you can access certain technology to measure it, that individuals can have access to treatment early to get the better outcomes. So as I've said, medical management of cancer has changed significantly in the last 30 years. Surgical management has changed. We're now doing much less surgery. We're doing very defined surgical procedures. Chemotherapy has changed. We are doing much more neoadjuvant treatment, so chemotherapy at the time of diagnosis to try to shrink the tumour. We're doing different types of radiotherapy. So radiotherapy used to be sort of daily for 6 weeks. Now it can be much, much shorter periods of time with the same effective results. There's questions about, do we escalate, do we de-escalate treatment? There's very much a role for hormone treatment, for immunotherapy treatments, and for targeted treatments that weren't available in the past. So we need to be thankful and pleased for the advances in cancer treatment management. And then we need to understand what are the risks now for lymphedema, because I think with lymphedema, sometimes we're held back on misinformation or myths that were previously known when cancer treatment was quite different. And I think we've got to get the balance right, and education is a key part of that, hence talking to you today. When we talk about defining lymphedema, this is also a challenge internationally because we don't have one tool that can measure all components of lymphedema. We have a variety of very good assessment tools that can assess various components of lymphedema. And as health professionals working in this area, we need to understand the different tools, how we can access those tools, and understand what they're measuring so that we can then make informed choices about taking measurements and then being able to educate our patients about the results of what the tools are measuring. So, for example, the good old tape measure is almost a badge of honour of being a lymphedema practitioner. I have a tape measure in my handbag, and you never know when you might need a tape measure. And tape measure is probably the most frequently used assessment for lymphedema, but it has its challenges. But if you don't have access to any other assessment tools, then use something rather than nothing. We have very high-tech assessment tools like MRI scans, like lymphoscintigraphy. We have pyrometry, which is like a glorified tape measure. We have indocyanine green lymphography, which is where we can see in real time what's happening, whether there's dermal backflow or congestion in the lymphatic vessels. And we also have bioimpedance spectroscopy. Now, bioimpedance spectroscopy is the picture on the right there. That is measuring extracellular fluid. And it's really been noted to be working in this early intervention space where it's really detecting those subclinical early changes in extracellular fluid that may just pick up early lymphedema before some of the other tools may actually be effective. So there's challenges. And I guess the message is, if you don't have access to any of these tools, even thinking about symptoms and self-report of what an individual is feeling is really important, because often an individual person at risk of lymphedema can pick up some early signs of heaviness, a dull ache, or something not feeling quite right. And if you've got those feelings as a patient or as a consumer going through cancer treatment, then perhaps it's really worthwhile you having an assessment with a lymphedema practitioner that can have access to some of these measurement tools. So why should we adopt a prospective surveillance and early intervention model of care in cancer care? A lot of the work has actually been done in breast cancer. So a lot of my references today and experience is in the breast cancer area, because that's where a lot of the scientific research has happened. But it's my goal that we get the model right in breast cancer, and then we pick the model up and we use it in all cancer areas where lymphedema is potentially a risk. So in the breast cancer area, there is significant clinical and governance evidence supporting the model of care. There's lots of key position statements and consensus papers, protocols recommending that individuals do participate in a screening program. And if you look on any of these websites internationally, you will be able to have access to those position statements or recommendations that do reference the scientific literature. Likewise, there is good clinical scientific research that backs up to the early 2000s. Small and large studies, prospective, retrospective, and randomized controlled trials that are really supportive of this concept of screening and early intervention implementation when subclinical lymphedema is triggered. And even more recently, there's large systematic reviews, meta-analysis, and some other ways of really trying to look at early intervention using compression therapy, even before we might even see lymphedema developing. So watch this space. It's something that we need to be aware of and something where there's a lot of work happening in. Now, some of you may be familiar with the PREVENT trial. I had the privilege of being the Australian principal investigator in the PREVENT trial, which was led by Professor Sheila Reidner from Vanderbilt University. Sheila is a great colleague of mine and taught me so much while we worked on this study for over 6 years. Gave me a few grey hairs at time, but it was an amazing experience to participate in an international randomised controlled trial. This study recruited 1,200 women who were diagnosed with breast cancer from these 10 sites. 9 of the sites were across the United States, and we were the only site outside of the United States in Sydney, Australia. The primary aim of the study was to determine if subclinical detection of extracellular fluid accumulation via bioimpedance spectroscopy and subsequent early intervention reduced the rate of progression to CDT or complex decongestive therapy relative to rates seen using standard tape measures, because the standard tape measure is sort of what generally people use in clinical practice. The early intervention for that study, and similar to other studies that are intervention study, is generally a 20 to 30 millimetre compression sleeve and handpiece, so not just the sleeve on its own, but handpiece, worn 12 hours days for about 28 days. So 4 to 6 weeks is generally the period of early intervention. However, I would say, despite the study showing that this is the time period for early intervention, in my real clinical experience and clinical practice, where I still see patients now, I would never really just take the compression sleeve off someone at the end of that 4 or 6 week period. I would be really looking at the factors associated with what's going on for that individual, where they're at, whether they're still undergoing intensive treatment, whether it's the peak of summer weather or they're involved in certain activities. I would be very much clinically working with the individual as far as weaning that person off. But the clinical trials supporting the evidence that I've shared with you recommend and completed 4 weeks of wearing compression 12 hours a day. The results of the PREVENT study, and these have all been published, so I'm not going to go into them in detail. The PREVENT study showed that there was significantly lower progression to chronic lymphedema for those women who were monitored using the bioimpedance, the LDEX device, versus the tape measure. We had less triggers of subclinical lymphedema, but you can see there a significant reduction in progression to chronic lymphedema. And interestingly, when we offer a screening program, I think we need to think about the timing of how long we monitor individuals. And you can see there that in our study, women were monitored for 3 years. A large proportion, 50% of them, were triggering subclinical lymphedema in those first 9 months. But you can see there that the 9 to 18 months, there is still another 22% of individuals triggered subclinical lymphedema, and right out to the 30 months period. So I really recommend that we consider this model as a 3-year screening model of care. And as I said, there's many publications that you can look up the full details and results across a variety of areas that we reviewed the data for this, and I'm happy to share them. They're mostly all on open access publications. So if we've suggested that we've got good clinical evidence to support this model of care, why isn't it standard of care now internationally? Because this study finished in 2020, 5 years ago, but still it's very patchy where this model of care is working effectively and where perhaps it's not. So what are some of the issues that we need to consider if we want to implement this model of care? So the first thing is that we really need to be working as part of this multidisciplinary team. It's a collaborative team, and we need ownership and buy-in from the whole multidisciplinary team. A breast surgeon can't say, I want to do this, without having input and support of allied health and nursing professionals. Likewise, the rehab team can't just take on the model of care without having support of the breast surgeon, the oncologist, to be able to really get the buy-in for the patients in this model of care. It's really important that you develop that monitoring or screening protocol. And although there's guidelines for this, it needs to be thought about in relation to your centre, how your multidisciplinary team works, what is the workflow where the patients come just to the one hospital setting or whether they're going across various health systems throughout their treatment. In Australia, sometimes people go to a public hospital for diagnosis and imaging, then they may have their surgery in a private hospital, they might come back to the public hospital for chemotherapy and go to a private facility for radiotherapy. So we need to look at how that works for the workflow for this screening program. And then, as I indicated earlier, if someone triggers subclinical lymphedema, we need to have a clinical pathway in place for that person to be able to access the early intervention. So it's no use triggering and identifying people who trigger subclinical lymphedema without having the pathway in place for a timely early intervention so that we can get that compression garment on, we can get the exercise happening early to try to prevent progression to clinical lymphedema. So education is a really important part of this throughout the patient journey and throughout the implementation process. We need education initially for staff engaged in this model of care, for referrers, so people know how to refer individuals to this model of care, and for patients going through the treatment. And that education will be at different levels according to the cohort you're speaking to. I think it's really important if you're setting out to implement this model of care that set it up as a quality improvement project or as an evaluation. It's really good to be able to evaluate the program, to be able to give feedback to service providers and people who have the purse strings to show that this program is effective from a cost point of view, but also outcomes that are showing benefit for individuals at risk of lymphedema. And of course, when you're considering implementing this model of care, you need to think about program resources, funding for trained staff and equipment. Even though, to stand someone on a SOZO device to do a bioimpedance measurement might take 5 minutes, you still need to work out who's got those 5 minutes in their day to be able to conduct those measurements. We also need to think about risk factors, and this comes up a lot, and there's a lot of published work in the area of risk factors for lymphedema, and this has certainly changed since the landscape of medical management for breast cancer has changed, and likewise in other cancers as well. From our PREVENT study results, we published a couple of papers about risk factors for lymphedema based on our 1,200 women cohort. The top row here showed the significant things that were definitely considered in the high risk factors for individuals going through cancer treatment. Those who have an axillary lymph node dissection, those who have regional node radiation, and those who have going through taxane chemotherapy. They're the three things that are pretty common across most papers who are published in this area. And our numbers of individuals having axillary lymph node dissection has changed a lot over recent years, but likewise we're doing more regional node radiation, or where a lot of women are going through taxane chemotherapies. The other interesting factors that came up from our study were the bottom row here. So individuals who had episodes of cellulitis from after they'd had their surgery or treatment were at a higher risk of lymphedema. Individuals who had a BMI of greater than 30 at the time of diagnosis of their breast cancer were at a higher rate of lymphedema. And interestingly for us as researchers, those who lived in rural areas also had a higher incidence of lymphedema. And I think we need to think a little bit more about that group of individuals who may come to a large tertiary centre for their treatment and diagnosis, but may then not come back to that tertiary centre for their regular screening or follow-up appointments. They may not be able to access that monitoring in their local centre, and perhaps we may miss some of this early stage subclinical lymphedema. So we need to think really carefully about risk factors. And I think we also need to be really thinking about personalised risk reduction education. In the past, when all women had axillary lymph node dissection, our education was pretty standard because everyone was at the same risk. I think that's where we need to do some work in the community to really look at our education, because a woman who's had one sentinel node removed, some conservative surgery, a wide local excision, and some targeted radiation to the breast is at a very different risk for lymphedema than someone who has had an axillary dissection, some regional node radiation, taxane chemotherapy, and a mastectomy. And I think we've got to identify and acknowledge that we can't be giving blanket education to everyone. We need to really think about personalising according to risk reduction and risk factors. So we did publish a paper, my colleague, Professor John Boyages, from the PREVENT study, and we developed this little traffic light table. So green is low risk, orange is moderate risk, and red is high risk. And I think when you're looking at implementing this model of care, this is something that's really useful, because management are going to look at, can you afford to screen every single person in the same way? I don't think so. I think we need to carefully select those who are at the higher risk and screen them more frequently than someone in that very low risk group. And this paper and this traffic light symbol is available on open access, or contact me for further information. Just wanted to share also about the cost benefits of implementing this early intervention model of care. So in Australia, there's a large project underway. They've currently recruited 6,000 women across 13 local health districts in New South Wales in Australia. And interestingly, a preliminary analysis looking at cost of implementing the model of care versus treatment for chronic lymphedema. And they alluded that for every $1 invested in lymphedema prevention, so implementing a screening program, they actually saved $8 in intensive treatment. That's pretty significant. And I think from a cost point of view, more work needs to be done in this area, but it's certainly much easier to screen people than to be doing the intensive treatment. So I just want, for the last few minutes of this presentation, to share how can we evaluate when we want to implementing this model of care into clinical practice as standard of care. How do we evaluate whether it's successful or not? So I want to share it through a case study from the PREVENT study. And I put this slide up, what is implementation science? And this is something very dear to me, because as a clinician, and I always call myself a clinician researcher, I'm a clinician first. And I love being a clinician, I love seeing my patients, and they keep me real. And when I'm doing my research or when I'm teaching, I've got real life patients who help inform me and guide and support me in how I do my teaching and research. But even if an intervention, and I shared with you, we've got some good scientific evidence supporting this model of care, even if an intervention is 100% effective, and the science shows us this is what works and is effective, it's only as good as how and whether this intervention is adopted, whether practitioners are trained to deliver it, whether trained practitioners can consistently deliver it with fidelity, that eligible patients can receive it, and that it can be sustained. And I think this is really important, because the science shows us this model of care works. It's a bit of a no-brainer. And sometimes I have patients referred to me who haven't had access to this model of care. They've developed a problem and they were referred to me for intervention. And when I tell those women that, normally I try to see women at the time of their breast cancer diagnosis, and we screen them over a period of time to get them intervention as early as possible, they feel really upset or really ripped off that they hadn't had access to the model of care. So implementation science is really interesting, because, as I say, it can be the most effective treatment, But unless we can implement it into the clinical setting and work out the challenges of that, then we're no good to anyone. So let's talk about a case study that I used with a framework of implementation science, and it's called the REAIM framework. And what this framework looks at is reach. How do I reach the targeted population? Who is the clinical load or the group that you're wanting to target to implement this model of care? How do we actually find them? Is it that we access them through surgeons? Is it oncologists? Is it through rehab teams? How do we reach the population that we want to implement the model of care? Effectiveness. How do I know that my intervention is effective? How can I follow up and understand that? The adoption. How do I develop organisational support to deliver my intervention? The lymphedema therapist might think this model is fantastic, but how do we get the buy-in from the organisation and management? Implementation. How do I ensure the intervention is delivered properly? And maintenance. How do I incorporate the intervention so it's delivered over the long term and it's not people dependent? So I actually published this paper, so you can access this one as well to see the results in full, but I'm going to just share them briefly with you. So as part of this PREVENT study, I did a retrospective analysis from a small group within that study that we had recruited for the PREVENT study. So in Sydney, we had 4 hospitals that participated in the PREVENT study. One of the hospitals was a large tertiary teaching hospital, and 3 were private hospitals. For this analysis, we did 219 Australian women who completed at least 24 months of their post-surgical follow-up to look at how things were happening in the implementation side. So this is a little bit about the clinical pathway here. So we've got 3 hospitals that were private and 1 that was public. And I'm looking here whether, before the study started, whether they had the model of care already in place, where we had baseline screening and education. You'll see there that 2 of the hospitals, 1 private and 1 public, had the green tick. They were already doing this model of care. So they had the support of the multidisciplinary team, the surgeons, to make this model of care work. And these people, whether they were public or private, were able to access this model of care as standard of care. The other 2 private hospitals, unfortunately, at the time when we started this study, did not routinely have this model of care working, despite having a fantastic team of surgeons and oncologists working in breast cancer management, a fantastic physiotherapy department with lymphedema practitioners, but they didn't actually access the patients before the study started. And there were challenges there. The surgeon said, you know, the women were too stressed and distressed at the time of their cancer treatment to try to book them in logistically to get a screening assessment. It was just too hard. So at the time before the PREVENT study, it wasn't standard of care. After we conducted the PREVENT study and we look back at these women, we actually had recruited out of these 219 women, 89 from the public hospital and 130 across the 3 private hospitals. We actually found that we were very effective in our recruitment because 25% of these patients were triggering early intervention for subclinical lymphedema. Only out of that group after 2 years, less than 2% of them progressed to clinical lymphedema, which is a pretty good stat in my book. What we found, though, as part of the PREVENT study, it was a resource study, so we had research officers who were able to contact these patients and book them in for these screening appointments. But what we did was we linked them to when they were having a routine medical appointment. So when they were coming in to see their surgeon or their oncologist, or when they were coming in for chemotherapy or radiotherapy, we linked their study appointment with that. And that seemed to be a really positive thing, that the individual woman didn't have to come in for a separate appointment for lymphedema screening. So again, thinking about your own setting and how can you make this effective. And what we found was that there was an overall positive perception on the efficacy of early intervention following their breast cancer treatment. The women at the time, because they were part of the study, they were getting free compression garments, and we actually found that they were wearing them, and the women kept diaries to be able to log how often they were wearing the garments. We also looked at quality of life and symptom surveys that we've got data on as well that supported their participation and the effectiveness of participating in this model of care. So in being able to adopt the model of care, so this is looking at the organisation support, any concerns we had in conducting the study, such as sometimes room availability and usage, these were addressed by our study team liaising with the key people who organised the room bookings so that we could obtain the rooms when we needed them. And sometimes we had to change rooms and move places, but that was a bit of communication and educating the teams, and that sometimes would have been the administrative teams or the people who did the bookings for rooms to accommodate us in the clinic spaces. The implementation side, we found that we were doing ongoing education to the multidisciplinary health professionals and also to the patients. So we set up sessions at the beginning of the study informing the multidisciplinary teams of what this model was. We shared the evidence with them. We got the buy-in from them from the beginning. And you know, we really looked at getting minimal disruption to the normal clinic flow, because we didn't want people saying, oh, they come in and they're taking our clinic rooms when we need them. We tried to make it a really smooth transition to make it work. And we really empowered the patients to take ownership of their care. And funnily, at the end of the 3 years, some of the women were really disappointed that the study was finishing, because they really felt they were getting a personalised care of support and empowering them to feel in control of their symptoms and that everything was okay, that they were getting monitored. In regards to the maintenance, how did people find coming for these appointments? We actually had really good adherence rates. Now, we did book these patients in to come for the appointments for the screening in line when they were coming for another appointment, but we had 92 to 100% adherence rates for all non-optional study appointments. And for optional visits, we had a couple of optional visits. We had a mixture of 40 to 77% of people buying in to come and be motivated to attend for these appointments. And we didn't see any differences between both the public and the private hospital settings, which was really good to know. And what happened was, at the end of the implementation of conducting the PREVENT study, we actually had ticks all round. The doctors at the private hospitals where the model of care was not implemented prior to the PREVENT study realised that we were able to make this screening program happen without the women getting concerned. The women were actually empowered and grateful that we were doing something to help reduce their risk of lymphedema and to help keep them informed and monitor them. So all of the teams then participated in referring these women for a baseline screening appointment at the time of their diagnosis, and that still happens across those 4 settings 5 years later. So when you're considering implementing this model of care, what potentially could be some of the barriers and the opportunities to implementing the model of care? So if we look on the left, the barriers, first of all, one point there for both barriers and opportunities is a paradigm shift. And what I mean by this is that if you're working in breast cancer or in any cancer groups that are where lymphedema is a risk and where this model of care is not currently happening, this is going to be a paradigm shift. So even though a screening might take a very short period of time to do, any additional workload or any change to normal clinical practice is a paradigm shift and needs to get ownership on board. So the barriers there that I've looked at are, you need to develop that screening protocol. You need to understand who are the high risk and the low risk, and how are you going to manage that within your own clinical service. And you need to have team meetings to work out as a team, where do you see the efforts need to be put. You need to look at staffing and resources, cost that needs to be covered, the time involved, both for patients, but also for health professionals implementing this model of care, funding for it, and this ongoing education. But on the flip side, there are many opportunities by implementing this model of care. It really helps to get that buy-in from the multidisciplinary team. Ultimately, we're about improving lives and improving outcomes for individuals at risk of developing lymphedema. And if we can do things to try to prevent the condition developing or intervene early to prevent it progressing to chronic lymphedema, then I'm in. I think it's less intensive treatment. So with this paradigm shift, we need to think of where do our resources go? If we're doing less invasive congestive therapy, then we could potentially put some resources to screening and monitoring. And we need to look at this as part of our holistic, multidisciplinary survivorship care for individuals. So just some thoughts on where you might go from here. If you're thinking, yeah, maybe we need to think about planning and looking at how we implement this model of care. It won't happen quickly. There needs to be a planning process. So think perhaps taking home from this webinar, what are some of the strategies you could plan in your own setting? Who do you need to talk to? What are the challenges you may face? What are the opportunities for engaging in this model of care? If you think a person-centered care model, if your cancer centre is like that, then think about the benefits for individuals at risk of lymphedema. Who are your key surgeons? You know, I've said today, surgeons, oncologists, medical and radiation oncologists, rehab teams, lymphedema practitioners, nursing, whoever's working already as part of that multidisciplinary team. What support networks do you need to seek out to help you in your planning? How are you going to evaluate it? You need to develop that as part of your plan. And how will you promote the program? Promote that you're a centre of excellence and that you're offering screening and early intervention. I encourage you to use supportive best practice documents and clinical evidence as part of your business case in submitting an application or a proposal to implement the model of care. Develop partners. So, you know, don't do it alone. Get the buy-in from your team. Perhaps organise appointments with the key stakeholders. Who are the purse holders? Who are the people who are going to help you and support you to make this work? And we need to be building on our education and our knowledge to improve the system, to improve lives ultimately. So my message is today is that I hope you can share my vision to improve lives by that every individual who's at risk of lymphedema through cancer treatment, that we need to be considering offering them this prospective surveillance and early intervention model of care. We need to work together. We need to collaborate. We need to share so that we can help to improve lives and reduce this condition lymphedema developing. And just a little plug that as part of our Alert Centre, we have an education program. We actually now have a formalised graduate certificate of lymphedema management. These are the units of study that make up our graduate certificate. But individuals can take on just units of study individually in the CPD space. And a large number of them are online units so that you can do them from wherever you are in the world. I will also acknowledge my colleague, Professor John Boyages. He launched his book this year, Lymphoedema Taking Control, that really outlines some of the evidence supporting this prospective surveillance and early intervention model of care, along with management of lymphedema. And I want to thank you for your time today. And I'm really happy to take questions, and I'm really happy to have further ongoing communication with you, or if you have any questions moving forward. So thank you very much, and I'll hand it over to you, Ajit, for questions and to field those questions. And feel free, if you want to join our alert mailing list to get our newsletters and updated research when that comes, scan the QR code and we'll add you to our mailing list, or follow us on LinkedIn. Thank you.
Thank you. Thank you so much, Dr. Koelmeyer, for such a fascinating presentation. I'm sure there are a lot of questions, and I won't take much of the time, and I'll jump right in on the questions. The very first one is I have an anecdotal no, I have anecdotally noticed that patients with cording earlier on have high chances of getting lymphedema. I'd love to know your insights about cording and its relationship with lymphedema. Do you have any insights, ma'am?
That's a great question. Thank you. I think with cording should be considered as part of that cancer rehabilitation program, and it can either link in as part of the screening program so that, for example, we would see patients and we would be doing a comprehensive assessment as well as screening for lymphedema. So what I mean by comprehensive assessment, we would be looking at those musculoskeletal effects like shoulder mobility, like cording, like scar management, like energy conservation, fatigue management, and psychological management. And sometimes you may refer to other health professionals if you don't have that discipline-specific information. I'm not sure that there's evidence directly supporting someone who has cording early on that goes on to develop lymphedema. I'm not aware of that evidence. But certainly I would encourage those involved in this model of care to consider having a bit of a tick box of those things I've mentioned as part of your screening program, so that you're not just screening for lymphedema and picking up subclinical lymphedema, but you're looking at those other musculoskeletal issues, particularly early on, because cording is very much generally occurs in the early days after surgery, early weeks after surgery, and certainly physiotherapists in Australia would see those patients to manage it as part of mobilising, shoulder mobilising and musculoskeletal work. So, yeah, not sure that there's any direct evidence, but if someone's got cording, it's generally that they've potentially had an axillary dissection, so they're in your higher risk group for lymphedema anyway, so they're probably having more of the intensive treatment and more of those higher risk factors for lymphedema.
Sure. Thank you so much. I have another question, which is like, I'm a lymphedema therapist and wondering if you could discuss a little bit more about early intervention with compression sleeves and monitoring for LDEC scores over time. You spoke about weaning out of sleeves over time. Could you speak a little more about the objective measures you might follow? How frequently you would measure the BIS or SOZO if
Sure.
someone's speaking positive of SCL, and are they wean out of the sleeve because of do you have any comments about that?
Sure. So I think, like I said when I was giving the presentation, I don't just take someone off a sleeve like we did in the study. And I have to say, as part of the PREVENT study, although we took the outcome measures for the study results for the primary outcomes was measured at the 4-week follow-up mark. That's what the results were presented and published on. As part of the PREVENT study, those women were allowed to continue wearing their garments, and they continued recording how often they wore it. So I would very much, with my clinician hat, so I wear a clinician hat and I wear a researcher hat. My clinician hat is that I work with the individual woman so that ideally they're wearing that garment for 10 to 12 hours a day when they're most active. So sometimes women want to take the sleeve and wear it only at night time, but we know that this compression garment has most benefit when someone is active, so it's helping that muscle pump to pump the lymphatic fluid through. So I would be monitoring more frequently when someone is through an early intervention period. So if I'm using a SOZO device and using bioimpedance spectroscopy as my measure to look at extracellular fluid levels, I might bring them back after 4 weeks or 6 weeks and then see what they're telling me. Have they got any symptoms? What is their arm feeling? I'd be feeling the texture. I'd be taking a comprehensive assessment and listening to the individual. Then we may get to a point that if they've finished their intensive treatment and it's in the middle of winter, I might say, well, maybe we can reduce the time of wearing the garment in the day. So instead of 10 to 12 hours, maybe you'd only wear it for a few hours in the day, or maybe you'd wear the garment every second day for a period of time with then a follow-up measure. So these women aren't then part of your normal 3-monthly screening. They would be then referred to the rehab team or the lymphedema practitioner, who would then monitor them and work with them with the individual sort of treatment plan to do a weaning. And it's very much based on individual needs, so individual needs and goals. Sometimes I have women who say, there's no way I want to wear that sleeve while I'm at work. And so you've got to respect that, but you need to give them some objective measurements to show the effectiveness or not effectiveness of what they're doing. And sometimes I will get my patients to really focus on exercise, wearing their compression, and then maybe reducing the compression and continuing the exercise. So it's very personalised when we get to the early intervention rather than a blanket for everyone. And I hope that helps that person.
Sure. Another question we have is, if you take into account of sensitivity and clinical feasibility, what early detection tools has the best potential to detect subclinical breast cancer related lymphedema?
Yeah, so I think the results of our PREVENT study showed that the bioimpedance was really outweighing the tape measure in that large randomized controlled trial. As a lymphedema therapist, I know that there's certain areas that can't necessarily access the SOZO device. And I'm very aware of that and in tune with that. So my advice is that you use whatever tools you can access. And the key would be to develop a very good protocol of trying to replicate or reproduce whatever you're using to measure so that you can do it again and again so that you're getting good, reliable data of how you're screening for lymphedema. So what I mean by that is if you're using a tape measure, then you need to have a protocol that you're always measuring at the same points across the limb and that you're getting consistency. Because the challenge with the tape measure is, the tension that you might pull on the tape, potentially could be a 0.5 centimetre or 1 centimetre difference unless you're using the same technique and everybody's using the same technique across therapists. So you need to be aware of that, of how you're measuring, and choose a tool that's going to be accessible for your patients in your clinic. But I wouldn't underestimate the power of patient self-report and symptoms that an individual is reporting. And I think there's a lot of work that has been published on that recently. Some colleagues of mine have done some work in that area where, if you haven't got access to the, good technology, then look at developing something rather than nothing.
Thank you. We have just time for 2 more questions. The first one is the effect of surgery duration as a risk factor for lymphedema. Do you consider it as a risk factor? What are your comments about that?
I haven't got any evidence that has measured the surgery time as a risk factor. I think I was talking to some breast surgeons only yesterday, and we were saying that sometimes it may not even be the number of lymph nodes, but it could just be the surgical technique or the anatomy of the individual woman to, how impacted the lymphatic system is. And there is work happening in the States looking at the anatomy. There's some people doing prospective or prophylactic LVA surgery. So I think that I don't know that the surgery time itself, that initial breast surgery time, has been looked at as a risk factor, and I'm not aware of research in that.
Would it be possible to certify patients as health educators specializing in lymphatic disorders? And would that help in freeing up therapist times to provide treatment?
I think we need to very much empower our patients, our consumers who are living with this condition or at risk of this condition, because there are lots of psychological concerns about, what do I do? What if, developing lymphedema can really be a significant survivorship issue for individuals. So I think we need, as a community, as a lymphatic community, we really need to be thinking about our education that we have. And I think there's a lot of misinformation out there in the community about the do's and don'ts, about what should someone do or what should someone not do to prevent lymphedema. And I think there's been some really recent research out there that is dispelling some of the myths that we've had in the past. So I think health professionals and consumers need to work together to be able to really understand what is the latest evidence supporting risk reduction, supporting dispelling or accepting some of the myths that are out there. And we need to all be on the same page and singing off the same song sheet of what's important for evidence-based lymphedema risk now.
Sure. Thank you so much. Thank you so much, Dr. Koelmeyer. This was a fascinating discussion that we had, and given the amount of questions we just had, I'm sure each and every one of our viewers has gained valuable insights from this presentation. Until next time, I'm your host, Dr. Rajit Mulay, saying goodbye and God bless. Thank you so much.